Okay. All right, Jackie, I can go ahead and start recording. So good afternoon, everyone. Thanks so much for joining us today. My name is Erin Smith, and I'm the program manager for the Maternal and Neonatal Designation Program here in Georgia. During this presentation, just a couple of things. If you have any questions, please type them in the chat or raise your hand. Both of these buttons are located at the bottom of the screen on the right side, and we'll answer these at the end of the presentation. I'm going to go ahead and introduce key people who have been instrumental in the newly published AAP NICU standards. I'm going to start with Dr. Ann Stark, who is the medical director of the AAP NICU verification program and has a long interest in neonatal risk appropriate care. She is an attending neonatologist at Beth Israel Deaconess Medical Center in Boston and has more than 40 years of clinical experience. She is a former chair of the AAP Committee on Fetus and Newborn, was the lead author on the initial levels of neonatal care policy statement, and also the newly published standards for levels of neonatal care 2, 3, and 4. I also want to introduce Nicole Faster. She's with us today as well. And Nicole's the senior manager of the NICU verification program at the AAP. And Nicole has a passion to improve care for all newborns. She's a registered nurse and has more than 15 years of level 3 and 4 neonatal experience. So thank you, Ann and Nicole, for joining us today.
Thanks for having us.
Thanks, Erin. So I'm going to pull up a couple of slides to kind of start. I'm just going to go over a quick, brief overview of the NICU verification program, kind of how to contact us and start the verification process through the AAP, and then I'm going to pass off to Dr. Stark, who's going to talk a little bit about the importance of verification. And then we're going to answer any questions that the individuals on the call may have today. We have a couple of questions that we've received from different individuals after the publication of the standards that we're able to kind of talk about today as well. But that's kind of what we anticipate for our time together today. So I'm going to go ahead and share my slides first, and then I will go ahead and get started. I apologize. Sometimes it freezes as I go ahead and share. So give me 1 second as this goes and works through this. Can everybody see my slides? Okay, great. So to start, as Erin said, I am Nicole Faster. I am the senior manager of the NICU verification program, and I really appreciate the time you're spending with us today. So just a brief overview of the process for engaging with the AAP NICU verification program. The first step is to submit a preliminary application, and that can be accessed through our website. And once that is done, we will reach out to the individuals who fill out that preliminary application to send an AAP business associate agreement and a participation agreement. The purposes of signing that first is that protects you at the facility level for protected health information and the individual information that is shared with us as a surveying body as we go through the verification process. Once those contracts are signed, we will work with you to work on your neonatal program description. The components of that document can be found in our standards that were published in May of earlier this year. And it outlines the things that are important to your facility and gives a description of the care that you provide. So this is a document that you will create. And the reason we have you work on this first is because once you finalize that neonatal program description, that gets uploaded into what is called the pre-review questionnaire. So generally, in regarding to the process, once you start to work on the neonatal program description and get closer to the end of completion of that document, we will then release to you what is called the pre-review questionnaire. This is a document that is completed in REDCap, so it's very secure, and asks additional information about your facility. So it talks more specifically related to your NICU quality and patient safety data, quality measures. It also talks about personnel and resources that your facility has, and provides our surveying team with a little bit more information about your facility. At the time we release the pre-review questionnaire, we generally start talking about when you would like to schedule your potential survey date. And the reason for that is we like to give facilities at least a minimum of 90 days to work on the pre-review questionnaire. This is an estimated time frame, but this is not required. And so if a facility chooses to have less time to complete the PRQ or longer time to complete the PRQ, that is completely up to the discretion of the facility. So generally we work around scheduling a NICU verification survey when we release that PRQ so that you guys have an estimated time as to when that survey may happen. Once those documents are completed, we will complete the verification survey, and at the time of the survey is when your facility will be invoiced. And then within 30 days, our team will provide you with a final report that summarizes the findings of the verification survey. So the verification survey itself is a 2-day process. We offer virtual and on-site, but we do recommend on-site surveys, especially for your first verification survey with us, so that we can really meet with the team members and have a collaborative survey over the course of the 2-day survey. So the 2-day survey on site is a day and a half. It'll be 1 full day on day 1 and a half day on day 2, whereas a virtual survey would be 2 full days. The difference in the time for the 2 surveys is just dependent on the additional debrief time we will need from the surveyor perspective, but also additional breaks, knowing that the virtual environment to sit within the survey for an extended period of time takes a lot out of individuals. The survey team composition is dependent on the level of care in which you are trying to achieve. So generally for a level 2 or a level 3 facility, we will send a neonatal nurse and a neonatologist. For a level 3 that is providing surgical services, we will also send a pediatric surgeon. And then for the level 4 facilities, we will send all 3 individuals, so a neonatal nurse, a neonatologist, and a pediatric surgeon, unless your facility is verified through the American College of Surgeons Children's Surgery Verification Program. In that case, we would not send a pediatric surgeon, and we would only send a neonatal nurse and a neonatologist. So over the course of the 2-day survey, we have interviews with key facility personnel. We do an in-depth review of patient charts and records to ensure compliance with your hospital's policies, procedures, and protocols, and to evaluate the level of care that is being provided. Each surveyor will do 8 records and will be reviewed over the course of that 2-day survey. We also do a review of credentialing files of the members who are providing neonatal care in your facility. So that will be from both a provider standpoint, a nursing standpoint, and ancillary team members as well. We complete a facility and unit tour, and then we do a comprehensive review of patient safety and quality improvement initiatives. So for the cost of a verification survey, the benefits of going through this process with us is that the Georgia Department of Health subsidizes half the cost of the survey price. So the survey prices are outlined here, and you can see the total amount, the subsidy that is provided by the Georgia Department of Public Health, and then the facility price for both virtual and on-site surveys. So I just want to briefly talk about the benefits to AAP verification, and then I'm going to pass off to Dr. Stark to talk about the importance of verification. So the American Academy of Pediatrics is the professional home for neonatologists. We have a group of neonatologists who are very engaged in the Academy through the section of neonatal perinatal medicine and our committee in fetus and newborn. We also really pride ourselves on the consultative and a collaborative approach. We really want to see your facility succeed. In Georgia, this is not a mandatory requirement to go through this designation process, but it is incentivized so that you can elevate that level of care. And so in order to do that, we really pride ourselves in being consultative and collaborative and providing guidance through the entire process of verification so that facilities feel that they can succeed when the survey actually happens. We also have the use of SmartVault, which is a HIPAA-compliant document sharing platform, which allows our survey team to securely share documents with the facility. We provide detailed instructions and survey guidance, and ultimately, at the end of the day, we want you to succeed. So we are really prideful and hope that you are successful in going through this process, and we really want to help you elevate your level of neonatal care. So I'm going to pass off to Dr. Stark to talk a little bit more about the importance of verification and why facilities should be verified.
Yeah, thanks, Nicole. I'm using your slides, right?
Yep.
Okay. So I'm going to talk to you a little bit about this. So you may be familiar with the CDC locate tool, which is really wonderful in terms of what it does, because it allows you to basically inventory what you have at your facility, and that is great. And they have an algorithm that lets them assign the level of neonatal, or if you're doing maternal care as well. And the problem with this, and can you move to the next slide that has the donuts on it? Yeah. There. So what they showed, and they actually published this earlier this year, that when they use the locate tool algorithm, that gives you, and that they have at CDC, and you compare that to what the facility does. There's about a third of the time the facility disagrees with what the locate tool algorithm tells them. And the issue is that they the facilities give themselves a higher mark than the locate tool algorithm does. And it's interesting because before Texas put into place their neonatal rules, they did a similar survey among all the sites in Texas that took care of newborn babies. And they surveyed the medical director of the NICU, the nursing director, and the administrator who was in charge. And they typically found that all three had kind of different answers, and that they always assessed themselves at a higher level than they actually were. So that's why a verification survey really helps. And do I have another slide? No.
Yep, that's it.
Yep.
So for the purposes of our discussion, I'm going to stop.
Oh, wait, I just wanted
Sorry,
to
go ahead, Dr. Stark.
I thought I had another slide, but no. I wanted to make it perfectly clear that what we want to do is have the facility succeed, right? Because that's better for babies. So the real advantage of having this is not only checking off, whether the standards are met, but also coaching a lot about how you could better meet the standards, how you can improve your quality improvement process, and so on. So that the more facilities that meet the standards, the better it is for babies. So it's not like we're trying to, nix you on anything. It's really to help you succeed. And another benefit of this survey is that in addition to identifying whether the standards are met, we also provide facilities with, and this is for your own use, a list of items that we think you do really well. And that's been really helpful because we've been able to pass along to other facilities some of the really good practices that some of our sites have had. And it's very helpful. And then we also have things that could be improved. They're, sort of a little shy of being perfectly meeting the standards, but if you did something another way, or if you needed more equipment and you needed something to help you negotiate with the powers that be at the facility, all that is very helpful. So we're happy to answer any questions that you have. And we're here.
So Dr. Stark, there is one question in the chat box that I'll read in a second, but I think it also aligns with a little bit of the process in Georgia and how there's there's two separate processes in the state of Georgia for levels of neonatal care. So there is the, and I'm blanking on it, Erin.
Certificate of need.
Yes, the certificate of need. I apologize. So the certificate of need. So the certificate of need identifies levels of neonatal bed, but only recognizes level 2s and level 3s in the state of Georgia.
Mhm.
The designation process is separate, and this is done through the Georgia Department of Health. And so the Georgia Department of Health recognized when they initially wrote their state legislation regarding levels of neonatal care that the certificate of need only recognized level 2s and level 3. So the initial rules that were written only outlined rules for level 2 and level 3. But there was an opportunity for the state of Georgia to write rules to be able to evaluate and designate level 4s, even though the certificate of need program does not recognize that. And so there was ongoing conversations with Erin and her team at the Georgia Department of Health to adopt the recently published NICU standards that allows for a facility in Georgia to be recognized as a level 4 through this designation process, even though the certificate of need does not recognize in that. And so with that being said, the two entities are separate. The certificate of need is a separate process that is independent of this Georgia Department of Health designation process. And so you would still be required to go through the certificate of need to have the applicable levels of care beds, but this Georgia Department of Health process would allow for your facility to be evaluated to the recently published standards to evaluate the level of care being provided and then be designated at that level through the Georgia Department of Health. This is not a mandatory process, but it is incentivized. And the benefits of going through this process align with what Dr. Stark just said. And so the question here says, if a facility fails the survey, do they have to pay again after correction, meaning the process starts all over again? And I'm going to defer a little bit to Dr. Stark and Erin, because us as a surveying agency, our job is to verify the care that is being provided in accordance to the recently published AAP standards of level of care. We produce a final report, and that final report is provided to the Georgia Department of Health, and the final designation status comes from the Georgia Department of Health. But I can tell you from our experience in working with the Georgia Department of Health that this is collaborative and not punitive. And so therefore the goal is never to downgrade a facility based on the level of care. And through our collaborative processes, facilities should have an understanding of the level of care they're providing and going into the survey itself. And if there's any concerns about not meeting that level of care, that discussion would happen prior to the survey. But Dr. Stark or Erin, do you want to add anything to that? And then maybe Erin touch a little bit about what that process after looks like.
Yeah, Erin, I would yield to you on this one. Our rule is to verify and what's there and what could be improved.
Correct. Yes. If this, were to happen and you didn't meet the standards, then I will work with you, your team, and we will come up with a way to rectify what what was missing.
Mhm.
Your question kind of is, do you have to pay again after? And we've discussed if we need to have a surveyor come out again. It really depends on the deficiency.
Yes, right.
As to that. So kind of we'd cross that bridge when we get to it. Most of the time, if there is a deficiency, then I can work with you all to help fix it.
Right, and that is actually the way it is in, for example, Texas, where if there's a deficiency, the facility needs to come up with a plan to address that deficiency, and that's reviewed by the Department of Health.
And so I think one of the examples that we've seen in the questions we've received recently that may provide a little bit of support to kind of show you the process as to how these things would be evaluated and handled would be recent questions that we received regarding the clinical nurse specialist for a level 4 facility. So in the standards, it states that for a level 4, they have to have a dedicated FTE to fulfill the role of the CNS. And the CNS either has to be be master's prepared or doctor prepared clinical nurse specialist, and that would require the certification of a CNS. Now, we recognize at the AAP, and even when we wrote the standards as the authoring group, that the CNS is limited due to different resources, for instance, lack of CNS programs, difficulty in obtaining that certification, potential lack of preceptors to fulfill that role. And so there's a huge need for CNSs in the neonatal world. And there's also a huge benefit to having a CNS at your institution to evaluate the care, but also implemented processes and procedures to really elevate patient safety and quality improvement initiatives. So one of the questions asked to us was, if there was an individual in the CNS role who did not have their doctorate, but was master prepared, but did not have the certification, would that meet the standard for a level 4? And so we've had internal discussions as the authoring group as to how that would be evaluated. And so what we recognize is there is limitations to facilities to have CNSs based on level, personnel, and just even geographical location. And so therefore, if a facility was able to put somebody in a role that met all the requirements of the CNS and had either a master's or was doctoral prepared, and they had dedicated time, that would suffice for meeting that standard. And that would be provided in our final report that would go back to the Georgia Department of Health, and then the Georgia Department of Health would determine whether or not that was a deficiency or not, or whether that was not. And Dr. Stark, do you want to add anything to those discussions related to that example?
Yeah, well, the thing that I wanted to add was that having an outside examination of your facility, one of the important things is that there is sufficient support for having a NICU from the hospital and the administration of the hospital. So if something is pointed out that might be viewed as a deficiency and could be remediated with sending somebody to school or paying for extra, by helping to buy equipment or anything like that, it really gets the attention of the C-suite. That's a good way to expedite getting what you need.
Yep. And our team would provide that documentation in the additional findings document that Dr. Stark had mentioned earlier, which allows your facility to have the documentation you need in ways that you could elevate your level of care or opportunities for improvement, to provide that documentation back to leadership to have additional support for the needs that you need for that level of care. So we are open to questions. Feel free to either come off mute or come on camera or put a question in the chat box. Otherwise, Dr. Stark and I can kind of talk about some other questions that we've received from facilities too, to kind of give examples as to other questions that facilities may have had regarding the standards. But we'll open it up to you guys first, and again, talk about some additional questions that we've received.
People are bashful today.
There we go. Amy?
Hey, Amy Thompson. I'm actually the medical director out at Augusta, whatever our name is now. We're now joined with Wellstar, but the Children's Hospital of Georgia. One of the questions that our group was discussing was regarding the on-site presence and the tracking mechanism for the response of being on-site if you are not in-house 24/7. What are some ways that other facilities have fulfilled this? Because there's been some just discussion within our group of the best way for us to demonstrate our adherence and compliance.
So do you have a policy that says what the time should be before response?
Yes, so we have a fellowship program, and that's sort of outlined in our ACG, goodness, what's the word? Oversight policy, our fellow oversight policy is sort of what we use for that. But the part that we were unsure about is the tracking mechanism for compliance to that policy.
For the attending
Yeah.
to come in. Yeah. Well, one way of doing it is for recording the time that either the fellow or the nurse contacted the attending. right? And then marking the time when the attending appears at the bedside. And that's how facilities do it.
Okay, so are they putting that sort of more in the medical record in the chart, or having like a separate outside of the chart response?
They're probably having a separate response
Yeah.
to document that. I mean, the time of call is often recorded in the chart, right?
Sometimes and sometimes not. You know, so
Right.
that's why we were trying to determine what the best way of doing that would be.
Right. Well, I think that's a choice that your facility has, but those are certainly two ways to do it.
Okay.
And what did you choose for a response time?
Currently in the policy, it's 60 minutes. Most of us are here between closer to the 30-minute mark is what we try, but to make sure that we are not falling outside of our policy for whatever other random reasons, we've done 60 minutes is the official policy. But our goal is closer to 30-minute response time to bed, from call to bedside.
Well, that sounds good. And that would be an opportunity for like a QI project as well, right?
Yes, yes.
Yeah. Sounds good. I mean, that's what we're all doing. We're working towards being better. You know, nobody's perfect.
I
Any
guess
other
if no one's
questions?
going to ask, I'll ask another question.
Go ahead.
Again, what we've been meeting with like leadership, but there's a couple of things that we have in place of trying to, one of them is our nurse educator FTE is currently not the one FTE. So we've been working with hospital leadership to get that bumped up. If there's a process for something to meet this standard, but it's not yet in place, would your recommendation just to be holding off on moving forward certificate of the site visit, or that be part of the fact that it's moving forward be taken into account?
You know, I think that every place is a little different. And as long as there's a defined route to completion, I think that would be reasonable. You know, it takes a long time sometimes to hire the right person. And so that would be taken into consideration. I mean, we're all just aiming to get better, right? And we recognize that not everything is perfectly in place. I mean, we want to get there. And if there's a real track of getting to whatever it is, that's great. We would take that definitely into consideration.
And you know, Amy, we all have worked in hospitals, so we know that it takes time, to get an FTE even. So, like Dr. Stark said, I mean, if it's in motion and you have a plan, in progress or in process, then we would definitely accept that.
Thank you.
Mm-hmm.
Mhm. All right. I don't see any other hands. Do you want to bring up some of the questions that you've received in the past, Nicole?
Yeah, so we can talk a little bit. So one of the first questions I'm going to bring up is questions that I received from an individual within Georgia who has a background in lactation and is also working collaboratively with the AAP chapter. And so I apologize, I don't see this individual, and so I don't want to call anybody out, but I do want to talk a little bit about the question. So there was questions regarding the choice of language for the certified lactation counselor versus the IBCLC for the higher levels of care. And so the reason certified lactation counselor was chosen for the level 2 in comparison to the level 3 and level 4 is because we didn't want to specifically call out the certified lactation counselor test or that specific certification, but it was more, the intent was to have a broader spectrum of certified lactation individuals versus counselors. And so that individual at the level 2 would be evaluated as a case-by-case basis. Again, to kind of talk about a lot of these questions that we're receiving is that the way the standards were written was that we didn't want to specify certain things, but wanted to put the ownership back on the facility just to kind of align with what we just talked about, like time limits and things of that for the facility to identify what that is for itself. So more specifically for the level 2, it says a CLC, IBCLC preferred, that ultimately that lactation individual and their job requirements would be outlined in their specific job requirements as to the certifications that they need. Ultimately, at the end of the day, we want everybody to have lactation support, and that is supported by our general program requirement that all direct care providers should have annual education regarding breastfeeding and the initiation of lactation. And so that is really supported, and the intent was that everybody who is providing direct patient care gets annual education on the importance of breastfeeding and lactation. The actual certifications required for those individuals will be outlined in the facility job requirements and will be evaluated in accordance with the standards and the needs of the patient population served. And so the CLC wasn't to call out a specific certification, but more of a baseline recommendation of there needs to be an individual that fulfills the role of the lactation consultant at the level 2, and their requirements for certification will be outlined in their job description. Dr. Stark, do you want to add anything to that?
Well, only that we're in the process of developing a manual that is going to provide additional explanations of many of these standards, so that we have standardization not only among facilities, but also among our surveyor staff. Yeah, that's coming.
And then the other question that aligns with that, Dr. Stark, is how will our surveyors assess whether or not a unit has the personnel with the knowledge and skills to support lactation available at all times? So do you want to speak to how our surveyors evaluate that?
Well, part of it is interviewing the people who are responsible, so we get some answers that way. And then as we do a tour of the NICU, we speak to parents who are there with their babies in spontaneous kind of situations, and we look at the documentation. So that, you know, and really see if that works. We look at documentation by lactation consultants. We look at what the nurses write in their notes, and so on. Anything to add, Nicole?
Yeah, so we also do the review of the credentialing files. And so we will be reviewing the annual competencies for the direct care providers that provide care in the NICU or special care nursery. So that could be, we look at staff nurses specifically, but we also look at the ancillary team members and the credentialing files of the privileged care providers and the neonatologists as well. So we're really looking to see the documentation of annual education regarding breastfeeding and lactation during that credentialing review process as well.
Yeah, and actually one of the key things that maybe deserves mention is that an important part of our site visit is to review a number of medical records. And we have our neonatologist looks at it from the medical side, and our nurse looks at it from the nursing side. So we get really a lot of information from what's documented in the medical record, and we kind of tell a story in the summaries that we provide, both back to the facility and that they ultimately send into the Department of Health.
Mm-hmm. We also do an in-depth review of policies, procedures, and guidelines. And so more specifically related to the initiation of breastfeeding, or some people will call it chest feeding. But to be cognizant of that, some facilities have even outlined procedures or policies or guidelines dependent on the facility as to kind of what that step for initiating those processes are. So for instance, at what level, oxygen level, can a patient or infant potentially dry nuzzle? Or when can you start initiating that process of putting babies to breast or chest? And so with that being said, there's also that evaluation to ensure that there is collaborative care happening between families and providers to ensure that the request to breastfeed or chest feed for mothers or parents is acknowledged and discussed, and so that plans can be put into place to advocate for that sooner than later. The other questions related to the lactation that we received prior to this call was for the standards regarding the designated area to prepare breast milk or formula feedings, and also for facilities to assess the lactation coverage on an annual basis. So all of our standards that were written were based on evidence-based practice or literature. And so there is different references that we pulled from to provide those standards. One of the big one was the perinatal guidelines for perinatal care, which was a publication by the AAP. But the also additional resources, and I can link them in the chat regarding specifically the lactation questions that we received, is that there is a book called Infant and Pediatric Feeding Guidelines for Preparation of Human Milk and Formula in Healthcare Facilities. This was put out by the American Nutrition and Dietetics. And then there's also a article that I can share with individuals as well, which was put out, I'm scrolling through it now, I apologize, by the United States Lactation Consultant Association. And it's a really nice article, or position paper, I should say, that says professional lactation support staffing in the hospital setting. And it actually gives a mechanism to evaluate how many lactation consultants you need based on the care that you're providing, more specifically patients or deliveries. And so that is an additional resource that I can share in the chat, in which that we pulled that information from when we wrote the standards. But to kind of piggyback on that, as Dr. Stark said, the plan is that we will be creating a supplemental resource manual that will outline these resources and provide additional information into how these standards will be met moving forward.
Yeah. And just, you know, to add to that, we didn't just make a lot of this stuff up. You know, we partnered with, when there are other organizations, for example, the neonatal therapy or therapist organization, and NAN, and you know, all those important organizations that have standards that they've written. We've partnered with them and adopted them into our standards. So we're grateful that at least some literature exists.
Sorry, does someone have a question?
That's okay. I was just thinking of, you know, what I've seen in the past about the like neonatal resuscitation, you know, and the staff certified in that. Can you touch a little bit on that? You know, by level, you want all level 2, 3, and 4 to, was it neonatal resus versus PALS or?
So anybody that has contact with newborns, either in the NICU or the delivery room, certainly we think should have certification in neonatal resuscitation. And so the neonatal resuscitation program is appropriate for small babies. Here in a big children's hospital, it may make where you're not getting preemies and early onset babies all the time. It may make sense for some or all of your providers to have PALS, because there are slightly different ways to resuscitate, from a baby who needs an airway problem most of the time, babies, and then slightly older kids who might be more apt to have cardiac issues.
And then for resuscitation specifically outlined in the general program requirements, so there is requirements related to resuscitation in the general program requirements that is applicable to all levels 2, 3, and 4. And so those guidelines are synonymous to what is written in the 8th edition of NRP. A question we recently received was when it says a NRP NRP trained provider, does that have to be a physician or an advanced practice nurse or a privileged care provider? The intent of NRP and our standards was that it does not have to be a physician or an advanced practice provider or a privileged care provider. It could be a nurse, it could be an OB, it could be
RT.
an RT, that somebody has to be in the delivery room for the management of the newborn and to initiate resuscitation if need be. That individual does not have to have advanced, credentialing or does not have to be a physician, but they do have to be NRP trained to be able to initiate that resuscitation if needed. So one question in the chat box was regarding the levels of care. So I will send our statement out to the chat box as well. I'm working on the other one on the back end as we're talking through this. I apologize for the delay, but I will again link our recent publication, the AAP standards for levels of care, and I can put that in the chat box as well.
Any other questions? Now, this has been a lot of information.
One other question we recently received in discussions and the collaboration we've had with the Neonatal Association of Neonatal Therapists is regarding the evaluation of swallowing concerns and whether or not an occupational therapist could have the certification to do that. We do recognize that there is different training for speech pathologists in accordance with physical therapists and occupational therapists, but there is additional certifications that neonatal therapists can achieve to be able to be certified to evaluate the swallowing concerns of NICU patients. And so therefore, we want somebody to have that certification or ability to evaluate those swallowing concerns. And so again, we understand that personnel resources may differ by level or by geographical location. But as long as there's somebody that is able and certified to evaluate swallowing concerns, that would meet the standards written by the AAP. Dr. Stark, do you want to add anything to that?
No, I think that that what you said is perfectly accurate. We understand that you can be a that you can have certifications to do swallowing, even if you are, not a certified swallow. So you can take the certification exam, even if you're an occupational therapist, for example. You have the training.
So I've linked a couple of things in the chat box. One is our AAP standards that were recently published in May. So those are called the standards for levels of neonatal care 2, 3, and 4. And that is what the Georgia Department of Health and the state of Georgia has adopted as the state rules for their designation and levels of neonatal care. I've also linked to that book I discussed, Infant and Pediatric Feedings Guidelines for Preparation of Human Milk and Formula. And I've also linked the article about professional lactation support staffing in the hospital setting, which kind of gives that formula for figuring out how much lactation support you would need for your institution based on deliveries or level of care and things of that nature. I think I have a couple other references that we pulled from, and so I will see if there's any more questions and work on those links on the back end. But again, Dr. Stark and I and Erin are here to support all of you guys. If questions come up, you can feel free to email us, ask for references and support in the preparation or in just general inquiries related to the standards, and we're more than happy to help in any way that we can.
Yeah, and all those references are in the publication.
Yep.
Because they're all cited by in the standards, yeah.
All right, well, if there's no other questions, then we appreciate you taking the time, all of you, and Dr. Stark and Nicole as well. So like Nicole said, feel free to reach out to any of us if you're thinking about all of this. As your day goes on, we'd be happy to answer any questions because we are here to support you.
Sounds good.
All right. Thank you.